myths in red, kind of actual truth in green on here. So people with eating disorders look unhealthy or quote unquote sick. That's not always the case. A lot of times you can't tell from the outside if someone has an eating disorder or is struggling with a relationship with food. Eating disorders are a lifestyle choice. It's not true. They're a result of genetic and environmental factors. No one chooses to have an eating disorder. Eating disorders are generally not that serious. Actually, they have the highest mortality rate of any psychiatric illness, namely anorexia, is what we're talking about there. Only females from upper socioeconomic status groups develop eating disorders. It's not the case. Eating disorders affect all males, females from all walks of life. And then anorexia is the only serious eating disorder. That's not true. All eating disorders are a serious issue. Some more myths. Strict dieting is not a problem. Strict dieting can lead to something more serious, might be the start of an eating disorder. Myth is that eating disorders are based just on food and weight issues, which we know they're not genuinely based on this. There's a lot of other things at play because it is a mental disorder as well. Younger students or elementary age do not develop eating disorders. That's not true. The highest increases in eating disorder development are in those of a young age. And then families are to blame for the development of an eating disorder. Families are not the reason someone gets an eating disorder. Like I had mentioned previously, they are a result of genetic and environmental factors. And then a lot of people think that full recovery is not possible. Like once you have an eating disorder, it is with you for the rest of your life. Full recovery is possible. So just a little outline of what we'll be talking about, just going through the different eating disorders and some medical complications that can come from that. And then the medical management of the female athlete triad and kind of what the workup looks like and what return to play looks like. And then just how this is applicable to everyone moving forward and kind of the main takeaways. So anorexia nervosa, or more commonly known just as anorexia, is basically like an obsessive fear of weight gain. And there's lots of things that can go wrong with your body. Basically everything can be impacted from this. It is the highest mortality rate of any mental health illness, and lots of things that can come from anorexia include amenorrhea, so that's missing 3 or more consecutive periods, osteoporosis, which is like minus 2.5% bone loss per year, can affect your stomach and GI, so gastroparesis, that's when your stomach stops contracting and moving food through it. So that can happen with anorexia. Dysphagia, that's what can happen when you're swallowing, your esophagus muscles stop working. So, if you're not eating, you're not using those muscles, and then you can get muscle atrophy and kind of lose that. And then there can also be like cardiovascular issues, heart and kidney and liver failure. I noticed there's a mistake right there. And then something that can happen with anorexia with treatment is refeeding syndrome. So anorexics typically have an electrolyte imbalance. So if they are refed too quickly, or that is not corrected before they are refed, that can lead to lots of organ failure. So with anorexia, they typically will have like magnesium phosphate and potassium imbalances. Bulimia nervosa is essentially like binging and purging, and this isn't just making yourself throw up. This can be abusing laxatives, using diuretics, or excessive exercise. So someone, binges and eats a ton, and then they have to go to the gym for all day to work it off and purge. So that's kind of where the excessive exercise comes from. Lots of things can happen with bulimia. One of them is like your GI tract can get very messed up from laxative abuse. So you are no longer to make regular bowel movements. You have diarrhea. It can just get completely messed up. And then again with bulimia, can be an electrolyte imbalance. So oftentimes they could tell you they're not purging anymore. You might not be able to tell that they're suffering from bulimia, but once you test their electrolytes, their potassium could be way out of whack. Hypokalemia means low potassium. And then edema can happen with purging episodes. That's just you're very swollen. Your aldosterone gets kind of out of whack, and you look very swollen. And then some other things that happen with bulimia from the throwing up, your esophagus can get very inflamed, your teeth can erode, and that's just from the stomach acids that you're vomiting up. And sometimes people even have like bruises on their fingers from making themselves throw up. They'll get cuts on their arms. So, there's lots of things that you can see that might be signs to look for in this instance. And then binge eating disorder. So this is characterized by frequent binging, so at least once a week for 3 months. And a lot of people don't quite understand what binging means. It's basically a loss of control. Like, you cannot control your actions, so that's what it is. So I'd put the diagnostic criteria on here just for some clarity. It's once a week for 3 months plus 3 or more of the following behaviors. So that's eating more rapidly than normal, eating even if you're uncomfortably full, eating large amounts of food when you're not hungry, and then, not eating around other people because you're embarrassed of your actions and you feel disgusted with oneself afterward, you're guilty, you're depressed, severe anxiety about your loss of control with food. And with binge eating disorder, a lot of the complications are the medical complications of obesity, so that's hypertension, high cholesterol, heart disease, and potentially type 2 diabetes. And then some other just disordered eating behaviors that you might not normally think about when you think of eating disorders. One is called RFID, or avoidant restricted food intake disorder. So what that is like essentially you avoid or restrict certain foods. For example, avoiding foods because of certain sensory features. So that could be like, this potato is squishy, I'm not going to eat any more of these potatoes. Or you're aversive to food because of fear. So something made your stomach hurt, so you're never going to eat food in that food group again because it made your stomach hurt one time. It's not associated with body image, so it's not because you want to be thin that you restrict, it's because you are aversive to actual food intake. And then other specified feeding and eating disorders are OSFED, so these are things that don't fall into the other categories. That's where orthorexia comes into play right now. That's kind of you guys are probably familiar with that term. It's an obsession with clean eating or staying away from unhealthy, quote-unquote, foods and bad foods. This is not an official medical diagnosis right now, but this is a pattern of unhealthy and disordered eating. And then over-exercise, exercise compulsion or obligatory exercise can be as a result of disordered eating. And then body dysmorphic disorder, so this is just obsessive thoughts related to your body. You don't have like a bad body image and your body part, it just causes severe emotional distress. And you'll go to great lengths to kind of fix that. So examples of that are like someone is so fixated on their right shin that they get plastic surgery and things like that. And then diabulimia, so that's in individuals that are type 1 diabetic, so that's when they misuse their insulin to kind of let their blood sugars run high to lose weight. So now going into more of an athletic population, I want to talk about the female athlete triad. So previously the female athlete triad was just disordered eating or an eating disorder, amenorrhea or loss of period, and then osteoporosis. And now they've kind of changed it, so it's now more of a spectrum, because someone might be struggling with some of these issues, but not all of them, so everyone kind of falls on a spectrum. So that's what this picture shows. Like, you might have reduced energy availability, you might not have a full eating disorder, you might be missing periods, but you might not have completely lost it, or it might have changed so it's not normal. And then your bone mineral density might be low, or it might have changed, but you might not fall under the osteoporosis category. And then going with that, I want to talk about the REDS category. So that means relative energy deficiency in sport. So that's kind of a more encompassing term. So it can encompass males with like bone health, menstrual function. Right here is the original triad, but there's so many other things that go on in your body. So this is the new like relative energy deficiency in sport. Excuse me, is like the terminology to help categorize athletes that might not fall under the female athlete triad. And then just here in this chart to the right, it can talk about some of the risks that you could have from not having, cardiovascular goes down, might be, a cardiovascular risk might be like decreased glycogen stores. So I think this is a really good chart and a good visual. And then I want to talk about the medical management of the female athlete triad, or RED, relative energy deficiency in sport athletes. All athletes are at risk. There's no one group that's more at risk than another. And then typically what a medical workup would look like for this, you get a full medical history, learn about any injuries they've had, stress reactions. You get a full meal history, so that would be with the dietitian to learn what their eating pattern is, if it's changed over time, if it's changed when they're in season or out of season. Learn their exercise history if they've ever struggled with compulsive exercise. And then you can kind of, from meal and exercise history, get a little better picture to see if they are in an energy deficiency and what that might look like for that person. And then the physical exam, just signs that you can see if their hair is brittle, if their nails are breaking, if they might have like more hair on their arm than usual. It can be another symptom of maybe a energy deficiency. And then looking at labs and tests. Electrolytes are important to test in this population, like I previously mentioned with the eating disorder diagnosis. Hormones, so estrogen and testosterone, see if those are within normal limits. Vitamin D, blood counts, and then going back on the bone mineral density is important to check. So if someone might be at risk for this, this is the full workup that they would get. And then just talking about the medical management in this instance. So this is like a collaborative effort to help the athlete, from the doctor, the dietitian, mental health, and the athletic trainer can kind of all work together to make sure that the athlete is meeting appointments and getting what they need. And then for just kind of return to play and what it might look like when an athlete comes out of their sport, if they have acute abnormalities on this medical workup, if they have stress fractures, then their exercise should be restricted, or they should have no exercise. And then for participants who are kind of working through this and working on improving, this is when you do a checklist. So if you meet these appointments, if you're consistently meeting goals, then you can start to reintroduce exercise. Start with 50% activity modification, and this is like low intensity exercise where you're at 60% of your max heart rate or less, and then you increase activity with consistent progress. So that would be gradual weight gain each week, or whatever is determined appropriate by the care team. And then right here is kind of a chart of like a realistic timeline of how long it would take to recover some of the energy status, menstrual status, and bone mineral density. So recovery of energy status, this could take days, this could take weeks. It depends on the individual and where they're at knowledge-wise. If it's just they don't understand what they need during the season and they're expending a lot more energy than they're bringing in, it might be a little easier to recover that energy status and get the process started. For some people who are struggling with more disordered eating or an eating disorder, this process could take weeks or months. Recovery of menstrual status can take months. First, you have to recover your energy status before that can happen, and then it could take months to a year for some people after the energy status is restored. And then bone mineral density can take years to go back to normal. So it's important in that case that they're not getting worse, they're just staying the same or getting better for bone mineral density. So just to talk about some signs and symptoms to look for that you guys can all be looking for with your athletes. Things when someone consistently leaves the table within 10 minutes after a meal, stirring or playing with their food rather than eating it, skipping meals consistently, or skipping meals and then overeating at another meal, having fatigue, restricting foods and food groups, expressing concerns about being fat or becoming fat, inordinate amounts of conversations about food and weight, and then just extremely rigid eating behaviors. And then also included some additional behavior in the male population. So these are some behaviors, and again, with all these behaviors, it's not saying if you see this in someone that they have a problem, it's just kind of getting everyone aware of what to look for potentially in the future. So additional behavior in male populations could be severe restriction of non-protein components, interrupting important activities to accommodate frequent eating, or eating even though you're full, liquefying or blending your food so you're able to eat more, use of appearance enhancing drugs, or restricting carbs and fats because they couldn't work out or had to deviate from the normal training. And then just something that I thought was really interesting, they talk a lot about in eating disorder treatment, the support that you get from your family members. Oftentimes with our athletes, they are away from their family, so a lot of the support they're getting is from the athletics faculty and staff. So I think it's good to know that those that struggle with bad relationships from food, it's kind of like a reminder that to externalize the eating disorder of those individuals. So we all have an internal dialogue And for people who struggle with a relationship with food and have an eating disorder, that eating disorder controls that internal dialogue. So, and then something that's important with that is like to not take someone from their treatment just because they're struggling and it's uncomfortable for them, but to support them through it. So an example that was given was, you know, you take your kid to swimming lessons and they scream and cry the whole time. You're not going to pull them from swimming classes, you're going to support them through it so they can learn how to swim and get better and, you know, learn something new. And it's the same thing with treatment. You know, they might be complaining to you, I don't think these appointments are working, I don't need help, but in reality you should just support them through it rather than accommodate them and take them out of treatment. So just emotion coaching as like a support system for these individuals. You want to validate their feelings. You don't want to tell them, I know this sucks that you have to go to see the dietitian once a week, but you need to do this. You want to tell them, I know this is hard that you want to see the dietitian every week because you have a busy schedule and classes are hard, and it'll help. So you just want to validate them, and then you want to support them next. So, you know, give them the emotional comfort that they need, but then also help them problem solve and kind of redirect it and figure out, you know, maybe I can work with you so you have more time with classes, so that seeing the dietitian once a week isn't as much of a struggle for you. So just want to talk about application for everyone. It's important to know the signs and symptoms. So there's like the 3 major eating disorders we talked about: anorexia, bulimia, and binge eating disorder. And we talked about the other disordered eating behaviors. So it's important to know the differences between the eating disorders and then recognize them and be able to report potential red flags. So those that are around the athletes a lot might notice certain comments they make in the weight room, behavior, talk from teammates, and then understand a realistic treatment plan timeline. So that was the big chart we showed, that it might take, you know, days, it might take weeks to recover your energy status, it might take months, it might take up to a year to recover your menstrual status, and then bone mineral density status can take years to get back to normal after returning to normal energy. I think so that's everything. Open for questions and feedback.
You had that chart, kind of like the wheel.
Yeah.
So how do you determine, it's like kind of like a loaded question, but it's like,
yeah.
How do you go about like determining which one of those are important and which one of them aren't, like on a case-by-case basis?
We actually have do you want to talk about in general or here?
Just both.
Okay, so this is like the REDS, relative energy deficiency in sports. So we have a REDS protocol, and essentially it's like a checklist, and you ask a few questions, and based on what their labs are, what their DEXA says, their menstrual history, we kind of determine if they're at risk and are a full-on REDS diagnosis, or if they're just someone that is kind of borderline. So there's like a protocol in place for that.
But this can also fall under males.
Yeah, and REDS, it's just like it's kind of a more encompassing term from the female athlete triad.
Are you done with your question?
I'm done, yeah.
So that's good. So if can you go to slide?
This one?
No, the other one. One more. Two more. Right there. So if they hit red, say that they're a freshman, and so if it's energy deficiency, but they're playing their sport,
Right.
and they're doing weights, and they're doing everything else. So how is it that that's ever going to get recovered?
Right.
Unless you're going to look at the coach and tell them that you're going to, because like on there, if you go back and then it's medical management,
Yeah.
it's the MD, RD, all that stuff. I get that, but then where do you look at a coach and you said, hey, like I flagged a freshman, but I know that menstrual cycle, that might take months. Are they going to continue to be on that when that energy deficiency might never go down? Like that whole load, how do you go ahead and manage that?
That's when the nutrition piece comes into play. So that's kind of like on that team's dietitian to make sure that they're eating enough and getting enough extra stuff so that their activity level doesn't have to change. But that diagnosis of that REDS designation will stay with them.
I hate to ask this question, but what if they don't have a base meal plan?
That's kind of tough, but you know, that's when you work on the athlete even more and talk about education and cooking, and might be something that you would go to the grocery store with that athlete, make sure they know what to buy. and then give them other, like, there's lots of products that are here available for those that don't have bank meal plans. So make sure that they're getting those and utilizing those that are available.
Would they ever be held out on a sport or anything else because of that energy deficiency? If we don't see its status change?
It depends on how they, like, the Reds protocol right now, it depends on how their, like, bone mineral density is and other. I mean,
It can't be, the answer is yeah.
The answer is could, yes, potentially, but it's not like,
just because they have a
yes, because of
diagnosis.
that.
Right. Depends
So-
on all the other factors.
So that's one of the factors you contribute to that. So your energy status is really depends on how relationship dietitian to the athlete. But if the status is now restored, plus have a lot of stress reaction, you have a couple factors will determine cut back to 50% of activity or something. Because you're not gonna test the hormone so frequently, but your report, dietitian's report, like that's documentation with the athletes, plus dietitian can weigh the athletes when they come to see the dietitian weekly and find a different way, like a picture or something, to do the food log stuff. That can back the athletes up, saying the energy levels there, this energy status is improving, body weight is kind of maintained or improving. That you can help the athlete do, and then help the medical staff know the athlete that part of energy status is there.
So like, does
So
that?
the number one overall risk factor is what? What are we preventing against? Is it the female? If it's a female, is it the female
Well,
triad?
I think the
Yeah.
biggest, the biggest thing for a female is going to be estrogen, right?
Right.
Like if you don't have estrogen, it's going to affect your bone health long term, which is also going to affect your heart health.
Yeah.
Which that one woman out of that class who went in California is doing a lot of research as it relates to the estrogen and the heart health. So I think the estrogen is a big piece / getting a period. Right? Because you're not getting estrogen
Yeah.
per se if you're not getting a period. Even if you're on birth control pills, the estrogen that your body's producing is kind of a fake.
Yeah. But, and
That's the only thing that I'm always confused about, because I look at it from the birth control standpoint, and I guess I would want to know what's the difference between the estrogen that we get, or some girls get from birth control, compared to a natural formulating estrogen. I'm not, because there's some doctors like Paynes who sat in that, and she said that it's sometimes a very good thing for our females to be on birth control. So I'm confused always about the estrogen, like natural occurring, or if it's through therapy
I
as
mean,
well.
it doesn't exist in a vacuum. So like, if I started taking steroids, there's all these cascade of processes that are going to shut down because my body's going to detect that my testosterone level is normal or abnormally high. So then all these other hormones start to shut off, and triggers a whole bunch of bad stuff, especially when I get off it. Now, basically flip on. Now you're over female hormone. When that goes away, I mean, it's going to be different with weight, but in estrogen, but the body's got to be weaned back into that normal state. So it's like a temporary fix.
Yeah,
Until you
and
get
I think
everything
a
else in
lot
place.
of doctors have been more vocal about how don't just prescribe the birth control because
It's
they're
not,
having these
yeah,
issues.
they're
It's like
really
now,
recommending not going
yeah,
that route
that's
right
like
now.
not the route right now.
If anything, an estrogen patch was a big thing.
Yeah,
that
or
we
like
talked
hormone therapy. So
Yeah.
looking
So,
for alternatives. Than
It's
just
like the one case we talked about today, for example, this kid came in with like a 1 point something on her bone density, right? It was Z-score. Now she's in the negatives, and she's maybe a junior, 2 years in, or 2 years in. So you see those negative trends, Stacy, and they're trending down.
Yeah.
I mean, and injuries start to go up. So then, yeah, they're going to be held out. Now, would they be held out if they weren't injured? They'd probably be restricted, I would think, on some of their levels. I mean, the Reds document has like a recommendation to use somebody in the activity.
Yeah.
My experience at the Division I level has been a lot of physicians aren't necessarily following that to pull them totally because how our coach is going to handle it.
Right.
The IOC document I sent you guys, I like from an education standpoint because it recommends like, okay, just so you know, your numbers are low, and this is what could happen to you. If you're okay playing on that, just you need to be aware. So
And that's what I was gonna ask, because like, where do we fall into that point of like relative risk? Like, you understand your risk. Like, we all know that you go play football. Like, they know that could be a risk that you are going to have a serious injury later on in your career. whatever, same thing with this. That's why it's interesting to know, because it's like we all take risks if you're gonna go out there and play. You're in an ACL, doing all that type of stuff. So where does the athlete sometimes have to say in that? Like, yeah, I get what you're saying, but at the end of the day, but I mean, if it's from a medical standpoint.
I do think they need more education and knowing that it can affect your heart, it can affect fertility,
And
all
it's like
that
long
kind of
term,
stuff.
it's not, you know, like you hurt yourself in a game, you're out for 8 weeks or whatever. You're not,
And bone
it's not
density
like
is hard.
down, it's down the line, it's years from now.
What did you say this orthorexia?
Yeah.
So you got an athlete that's dead set. This is how I'm gonna eat. This is the way it's gonna be. This is the way I'm always ate.
Yeah.
Maybe it's parental influence. Maybe it's he just picked it up. How do we? Let's say he's restricted carbs, but I think we feel like he needs carbohydrate.
Mm-hmm.
How do you go about that when he's dead set? She's dead set.
Right.
You know, not want to.
And I think that like diving in and developing a relationship with that athlete, number one, is so important. And then kind of being able to dive in with them and ask them, I think it's important to anyone who's trying to do any diet is ask them, what are my reasons for doing this? And kind of be able to have that rapport with them so you know, why am I doing this? What are my reasons? And then ask them like, is this a sustainable behavior? And when people ask about any type of fad diet or anything, it's like those two questions are so important. And then you can maybe start to ask them like, can I provide a little education on this? Like, just listen to me for 2 seconds today, and then maybe you follow up in a week and they listen a little more, and then like slowly, instead of, you know, reintroducing like food carbs, so like starting to eat potatoes and more vegetables that are starchy, to get carbohydrates from that before transitioning to maybe, you know, some more processed carbs or carbs that aren't from real food sources. So I mean, it's hard on people, but.
Do you think, like, I'm sitting here and you had some slides about like this internal voice
Yeah,
and things like that. It reminds me a lot about like addiction
yeah,
and a little bit of like this little devil inside of me saying, I can do this and maybe operate in secret
right,
and still be functional. So how do you go about, so I
Yeah.
develop a relationship with the, or the female athlete
Right.
and they're still battling something.
right. And that's just like, that's such where the mental health piece is huge. So if they're only seeing the dietitian and they're not doing, you know, making their mental health appointments, then they're not getting the full treatment that they need.
Eating disorders is a mental health condition.
Yeah, like mental health professionals diagnose eating disorders, like dietitians can't be the ones to diagnose the eating disorder. We just help them with pieces that.
Did you diagnose disordered eating? Is that
Well, like technically, so like eating like a lot of those disorders, like orthorexia, that's not a diagnosable medical condition. So there's like the DSM-5 criteria that if you have this behavior and this behavior and this behavior, then it is eligible to be diagnosable for anorexia, or you can diagnose binging or bulimia. But with like orthorexia or some of those other disordered eating behaviors, that's not a diagnosable condition because they don't have diagnosable requirements. I mean, you can as a dietitian, like just from like education and consults, you can kind of understand that person's relationship with food and work with them to improve that by providing education and working on their intake. But it's not like an official diagnosis.
What incentive does the athlete have to put any faith in this
Yeah.
and take what you're saying to heart, respond to your education, you know, what have you, if ultimately it's not going to impact anything they do from a playing standpoint?
And I mean, it's so individualized.
Up to and including the point they get injured, and obviously it's impacted there, but I just don't see an incentive for an athlete to really, you can tell them,
Yeah.
like, hey, this is going to impact you when you're 30 or whatever,
Yeah.
okay? Other than if we're not saying, hey, you're not going to participate in your sport until this gets squared away.
Yeah, and for some people, the sport participation, that's a really big motivator for them. For some people, it might not be. They might not be even as into the sport as they were previously, so that can be very difficult. And I think some people, it just takes something to happen. Like, you are pounding into them, like, this is important, this is why it's important, and they aren't going to take it seriously until they might get a stress reaction or a stress fracture. and then they might kind of come around to the idea and be like, okay, this is a long-term problem that I need to solve
Right.
for later in life.
So, again, and I don't expect you to have the answers to this, but
Yeah.
if ultimately at this end of the deal is non-sport participation because they're
Yeah.
injured, why doesn't it happen sooner than later?
Yeah, and I mean, I think that sometimes it's hard to tell if someone has a problem, and that is just on like, that's why it's so important to know like the signs and symptoms and be able to, you know, take note of people's conversations. If they're always making comments about something in the weight room, or they're always making snide remarks at traveling, you know, at the team dinner, that's why it's so important to understand that these things are real and kind of recognize the signs and symptoms before they get too far.
Severe cases are going to get put on a contract,
Yeah.
as you
Yeah.
should be aware of on your team now.
Get put on a contract.
Like a contract for participation, so like I have to make this progress, I have to
Meet this appointment.
meet this appointment, and if people are still not doing that, then they will be transferred to like a higher level of care. I mean, with eating disorders, they're serious diseases, so you know there's 24/7 residential inpatient care that people can be in for. I want to say the average stay was like in the 90-day range or something. And then typically they'll transition to like an intensive outpatient program or partial hospitalization. So even those are very kind of stringent, but they are contingent on someone following the rules and the high level of care. And even then, like people have relapses. There's people who have been in inpatient eating disorder facilities more than a dozen times in their lifetime. They're older and they've struggled with it. They've never, you know, just because it's easy to fall back. Sometimes it's an insurance issue. They can't stay in as long as they need it. They have to get out or come to outpatient, and they still should have been in residential. So I think that's another struggle.
And then just one last thing just came to my mind. Is it more important with these things to be more proactive than reactive?
I mean, definitely to, and I think that can be spoken on in all types of injuries, in the athletic setting, in any setting. Does that always happen? I don't think so, because I don't think people are aware of the severity of these things once it gets to that point.
I think our group right now, I mean, we've got 28 cases, and I would say a solid 20 are probably red's borderline.
Yeah.
And so I think the monitoring that we're doing
Yeah.
is a big prevention
Yeah.
piece.
I think there's been a big push within the Baylor athletic department of being proactive on these cases, and also like seeing someone, if they're okay now, we're not going to let them just go away. Like they're on the radar. There's different classifications, so that's been another big push recently. Anything else?